Hi guys, good evening. I hope I'm audible, I'm visible. Hi guys, good evening, good evening. Can we all get started? Audible and visible, right, great. Chalo. So, as we were saying, we'll continue our BLS series on trauma series today. It's about vascular injuries. So, we'll talk about the vascular injuries as we build up the lecture. But before we start core vascular injuries, I would like you to begin with the basic concept of whenever there's a vascular injury, there is volume loss. And whenever there is volume loss, the patient goes into shock, right? So, today's objective is to simplify the objectives of shock. So we'll try to understand that what is this shock. We'll try to understand what is shock, or per se when we call about it is a traumatic shock that we're going to talk about. So when we talk about shock, the shock is classically described as the systemic state. It is described as the systemic state of low tissue perfusion. It is defined as the systemic state of the low tissue perfusion. So when I say systemic state of low tissue perfusion, what do I mean by this, right? I mean that there is oxygen delivery to the cell is going to be reduced. So I can say the oxygen delivery to a cell or a tissue is reduced. So this is what the basic concept of shock is all about. Shock में क्या हो रहा है? Oxygen delivery to the cell or the oxygen delivery to a particular form of tissue is now getting reduced, right? Now, if you take this as the representation of the tissue, take this as the representation of the tissue, and let's say this is the vessel that is supposed to supply the blood to this particular block of tissue, right? Now, once the circulating blood reduces, it is because of volume loss. So what is going to happen? The blood going into the tissue is going to reduce. Now, as the blood going into the tissue is going to reduce, the oxygen delivery to the cell is going to be reduced. Whenever the oxygen delivery to the cell is going to reduce, what is going to happen? The aerobic respiration which is present here is now going to convert into the anaerobic respiration. It is going to convert into the anaerobic respiration. Now we'll say, let it happen on aerobic or an anaerobic. How does it differ, or it is going to change for us? So when we talk about the aerobic respiration, we all know the end product of the aerobic respiration is going to be carbon dioxide and water. Water is retained and the carbon dioxide is going to be exhaled out. But when it comes down to the anaerobic respiration, the end product of the anaerobic respiration is going to be the lactic acid. It is going to be the lactic acid. So what is going to happen? The concentration of the lactic acid will continue to increase in a particular cell. And when the concentration of lactic acid increases in the cell, it will activate the lysosomal enzymes within the cell, which will cause cell disruption. Now, as the concentration, so if you take this as a representation of the cell, as the concentration of the lactic acid is going to increase in the cell, it is now going to activate the lysosomal enzymes, and due to activation of lysosomal enzyme, it will result in cell lysis. Now, because it results in cell lysis, you will see excessive amount of lactic acid is being secreted into the circulation. So you will see the concentration of the lactic acid. The concentration of the lactic acid in the circulation is now going to shoot. Now, when it increases, it is now going to result, because it is an acid. Now, as the component of acid increases into the circulation, it will now going to result in metabolic acidosis. So that is why every patient of shock, where there is a low tissue perfusion, Because of that low tissue perfusion, patient will develop metabolic acidosis. But more importantly, we all know inside the cell you have more concentration of potassium. Now, as when the cell bursts open, you'll see excessive amount of potassium is going to be excreted. Now, as potassium comes into the circulation, transient hyperkalemia will also be noticed, right? So, in an initial phase of shock, the transient hyperkalemia, that is excessive amount of potassium, is going to be found. Now, when you look at this, how does it balance off, right? Let's try to understand how whole body, as in how it is going to work. Now, as I say, there is low tissue perfusion. That means the oxygen delivery to cell is reduced. That means the circulating blood volume is going to be reduced. So, what I'm talking about here, I'm talking about the circulating volume of blood. The circulating volume of blood is going to be reduced. Now, if the circulating volume of blood is going to be reduced, that means the blood going into the kidneys will decrease. So, I can simply say that the renal perfusion, is going to decrease. Whenever the renal perfusion is going to drop, whenever there is decrease in drop of renal perfusion, obviously the GFR is going to decrease, right? You will notice that the GFR is going to fall. Whenever the GFR reduces, in order to compensate for decrease in GFR, where always, whenever the GFR falls, obviously urine output will also reduce. Body says whenever the GFR falls, it wants to compensate, and the compensation comes by the activation of renin, angiotensin, aldosterone system. It is going to get activated. So whenever the RAS systems get activated, it will cause excessive production of aldosterone, right? So it increases the aldosterone level in the body. Now we all know what is the basic function of aldosterone. Rather than trying to remember it each individual component, I can give you a small mnemonic. It is going to be A, B, C, D, and E. A stands for, it is responsible for absorption of sodium and water. It is responsible for absorption of sodium and water. B stands for blood pressure maintenance. C, D is the collecting duct. C is the collecting duct, and D is your distal convoluted tubule. These are the two sites on nephron. These are the two sites of nephron on which the aldosterone is going to act. And E stands for excretion of potassium. It is the excretion of potassium, right? So whenever the circulating volume reduces, your GFR falls, RAS systems are activated, the blood pressure maintenance occurs by causing a vasoconstriction. It acts on the collecting duct and distal convoluted tubule of the nephron, and it promotes the excretion of potassium. Now, all this hyperkalemia that was formed, this problem will be taken care by your aldosterone. That is why, even though after an episode of the lactic acidosis, where the cell is going to get burst open because of the activation of lysosomal enzymes, we expect metabolic acidosis to occur. This will happen. But why you will not see hyperkalemia? Because that excessive potassium that is released into the blood will be flushed out by the aldosterone. And that is how the balance is maintained during the status of shock. Is that clear? Now, this forms a very, very interesting basis of the compensatory mechanism, because as we continue to talk about shock, now we'll talk about various compensatory mechanisms, we'll talk about various componental mechanisms where the body is trying to fight. So body is a great fighter. Body says, I will not let go so easily. I will fight till the last ounce of my strength. And this is one such example. Okay? So this is how you will notice that the patient is still continuing to fight, right? Now, I can continue to go on and on in terms of mechanism. One more thing that I would like to just state across here, that how does your heart respond to it, right? So we'll talk about the response of the heart to the hypo, or I can say less circulating volume of blood, right? So we'll talk about the response of heart to shock. So all this is going to be during the compensatory phase. Okay? Now, how does the heart is going to respond to? So when you take this as the representation of the heart, take this as a representation of the heart. Now, heart has got 4 chambers. I'm just going to depict it in this particular form. This is the right atria. This happens to be the right ventricle. This is your left atria. This happens to be the left ventricle. We all know the blood that is going to come into the heart will come from the right side. So it is going to be via the IVC and the SVC, which is going to give the blood to the right atria. And from here, the blood is going to be pumped out from the left ventricle via the aorta. It is going to be via the aorta. So this is the outlet where the blood is going to go out, and this is the inlet from where the blood is going to reach into the heart. Now, as I'm saying, there is decrease in circulating volume of the blood. That is what the shock is. The shock is the blood is not able to get adequately present, or the body is not able to have enough amount of volume. So what is going to happen? The blood going into the right atria will reduce. The blood going into the right ventricle will reduce. The blood going into the left atria will also reduce. That means the blood entering into the left ventricle will also reduce, right? Now, there's a concept which we have already discussed, right? The amount of blood which is available in left ventricle just before the contraction. So if you take this is the status of the left ventricle. The amount of blood that is available in the left ventricle just before the contraction. Just before the contraction, this is what we call it as the preload of the heart. And the amount of blood that is available in left ventricle after the contraction has occurred, this is what we call it as the after load of the heart, right? So preload is the amount of blood available in left ventricle before contraction, and after load is the amount of blood that is left behind the left ventricle once the contraction is done. So before contraction, the blood in left ventricle, and this is the blood available in left ventricle after contraction, right? So where did the rest of the blood go? With every single contraction, when the blood ejects out, this is what we call it as the stroke volume, or I can say with every single stroke, this is what we call it as the stroke volume or the stroke volume, or this is going to be measured per contraction. This is measured per contraction, and if you do it per minute, then it is called as the cardiac output. Cardiac output will be measured as per minute. If you do the same thing per minute, which will be called as cardiac output, but if you measure it per contraction, this is what we call it as stroke volume, right? Now, as we all know, the amount of blood coming in the left ventricle is going to reduce because circulating volume is less. So preload is going to reduce. So if preload reduces, what will happen to cardiac output? The cardiac output can be simply measured as preload minus afterload. Now, if you look at this, if this value decreases, the overall cardiac output will also decrease. Simple, right? So what is going to happen? What is going to happen to the cardiac output in shock? It reduces. It reduces because of this particular component, right? Another very interesting thing that you will notice is as the amount of blood available or coming into the aorta, when the cardiac output drops, the blood coming into the aorta will drop. If the blood coming into the aorta will drop, the aortic pressure will drop. The aortic pressure is nothing but systolic blood pressure. Now, when you say blood pressure, it is the pressure exerted by the volume of the blood onto the lateral walls of the vessel, and that is going to reduce. Now, whenever the pressure drops, you have a specialized receptor which is present at the arch, or I can say it is present on the arch of aorta, and that is what we call as baroreceptors. Now, one basic thing about the baroreceptors that we all should know. So what is the magic about this baroreceptor? Now, the baroreceptors are present at the arch of aorta as well as at the carotid bifurcation. Every single time there's a drop in pressure in the aorta, the baroreceptors get activated. When the baroreceptors get activated, they will cause activation of sympathetic system. When the sympathetic system gets activated, they will cause excessive release of catecholamine, that is epinephrine, as well as norepinephrine. The effect of epinephrine, norepinephrine on the heart, it is going to increase the heart rate. So you will notice the heart rate is going to increase. You will notice the heart rate is going to increase, right? Now, all this is what is your response of the heart to a low circulating volume. Is everybody clear with this? See, all these are hardcore concepts. If you love understanding a particular real mechanism behind something which is happening in your body, this is the best way to learn it. You understand, you analyze it, and then you know the exact reason about why or what is happening, and then you would know the exact status. Okay? So whenever we are learning, we'll always try to emphasize on the concepts so that we know exactly that what you're looking for. Okay? Clear? So In the same context, what is going to happen in lungs? We say response, we say same thing. We talk about response of lung to shock. We have the response of lung to shock. So as we understood the response of the heart, the response of the heart to that of shock, we'll talk about response of lung to the shock, as simple as that. Okay? Now what is going to happen? Any patient who has shock, we already know the patient is in metabolic acidosis. The patient already have metabolic acidosis. Now this metabolic acidosis is also a stimulatory factor for your sympathetic pathway. So the sympathetic system is going to get activated. When the sympathetic system gets activated, the effect of sympathetic system on the respiratory rate, what is going to happen? It is going to drive in, so the respiratory rate will increase. If the respiratory rate will increase, what will happen? It will result into carbon dioxide washout. Now if there is a carbon dioxide washout, it will now result in respiratory, it will result in respiratory alkylosis. This is more like a compensation to the metabolic acidosis. Because this metabolic acidosis, to compensate that metabolic acidosis, there will be presence of respiratory alkylosis. So respiratory alkylosis is the compensatory mechanism that has been brought towards by your lungs. Okay? Correct. Absolutely correct. Okay? So if you understood this is how your body is trying to compensate and play around, we'll try to understand and analyze the basic parameters of the shock. So before we move any further, I'll be talking about three basic types of shock. One, we'll be talking about the hypovolemic shock. One we talk about hypovolemic shock. Another one we'll talk about the cardiogenic shock. We have the hypovolemic shock, the cardiogenic shock. What is the third variety of shock? Right? What is the third variety of shock? Now, everybody who's thinking, no, so the third variety of shock, we'll talk about neurogenic shock, septic shock, anaphylactic shock, we'll talk about the spinal shock, all that nonsense, and going on. So, yeah, doesn't matter. Remember, the third variety of shock is basically what we call it as the distributive shock. Now, in the distributive shock, I will take one particular example of a distributive shock to explain. We'll talk about septic shock. Now, septic shock is an example of a distributive shock. Septic shock is an example of a distributive shock, right? So our idea or objective is to understand that how do you analyze these different components of shock which is present. Now, the parameters on which we are going to look across all these shock status. Number one, I'll be looking at what is going to happen to the cardiac output. We'll see what will happen to the systolic blood pressure. We'll talk about what will happen to the heart rate. We'll see what will happen to JVP. We'll see what will happen to pulmonary capillary wedge pressure. We'll talk about what will happen to pulmonary capillary wedge pressure. We'll see what will happen to the peripheral vascular resistance and what will happen to the skin temperature. What will happen to the skin temperature? So look at the cardiac output, we'll look at the systolic blood pressure, we'll look at the heart rate, the JVP, the pulmonary capillary wedge pressure, the peripheral vascular resistance and skin temperature. These are the parameters on which we are going to judge various components of shock, right? Various components of shock. Now to understand this, there's a small circuit that we have. Now what is the circuit and how do I describe it? Now let's say this is what the basis of the circuit starts from, that is going to be the heart. Right? Now the heart is divided into four chambers. We all know the four chambers of the heart. It is going to be your right atria, your right ventricle, your left atria and your left ventricle. Now from the left ventricle you will see the aorta is going to arise and the aorta is going to supply the blood to every nook and corner of the body. Now as it supplies the blood to every nook and corner of the body, I am going to divide the supply into two channels. One which is going to supply to the vital organs and one that supplies to non-vital organs. So this is the supply status. One that is supplying to the vital organ and another supply that is being supplied to the non-vital organ. To the non-vital organ. So one supplies to the vital organ, another one is to the non-vital organ. Now once the blood is being supplied across, obviously the blood is going to be recollected from the vital organs as well as the non-vital organs, and it will be collected in a circulating pool. Now for our comfort, I'm going to name this as the vascular pool. Now from the vascular pool, the blood is now going to return to the right side of the heart. The blood is now going to return to the right side of the heart and the circuit is completed, right? So blood starts pumping from the heart, it goes into the aorta, goes into vital, non-vital, comes back to the vascular pool and it reverts back. As simple as that. Now, a couple of important things that we need to understand before we jump into our discussion. Now, remember, whenever we talk about the right atrial pressure, the right atrial pressure is measured by jugular venous pressure. So JVP is actually a fancy word to tell you that it is measuring the right atrial pressure. So what is the fancy word to tell you that I'm measuring the left atrial pressure? That is nothing but your pulmonary capillary wedge pressure. PCWP is nothing but pulmonary capillary wedge pressure, which is going to measure the pressure of your left atria. Then you have at the arch of aorta, you have the specialized baroreceptors. We have already discussed about the status of baroreceptors, that whenever the pressure in the aorta or the vessel drops, the baroreceptors get activated. It will activate the sympathetic pathway. From there, it will release catecholamine, epinephrine, norepinephrine, and causes increase in heart rate. Now, as the blood is going to go from the aorta into vitals and non-vital organs, which organ will get more amount of blood? Is it the vital or the non-vital? Obvious, the answer is vitals. But then who is going to decide that vitals are going to get more amount of blood when compared to non-vital organs? Who is the one who is going to decide? So we know the baroreceptors here, but there's somebody who's deciding for them also, and this is your peripheral vascular resistance, right? It is your peripheral vascular resistance. Now, peripheral vascular resistance is a concept which tells you that more amount of blood will go to vitals and less amount of blood will go into non-vital organs. Now, how do you understand this? For that, we'll take a small analogy. Imagine that you're driving a car, right? And this is the road that is there, and it bifurcates into two different roads going forward. This is road A, this is road B, right? Now, as it is like a big highway, and you can see that the highway splits into two bifurcations, into road A and road B. Now, I know all you intelligent people, if I say which road will you take, you will say, sir, whichever road takes to my destination. Imagine both the roads are going to take you to your destination. Which road will you pick? Now, imagine there are multiple cars which are driving here. A lot of cars which are present on this bigger highway, and all of them are driving with a high speed. Now, as they approach the bifurcation, you will see the majority of the cars would prefer taking road A because it is wider and it offers less resistance. Once the road A is filled up, then you will see that the few of the cars will now start taking road B. So road B is not the road of choice. Road B is only taken when there is no space in road A. And this is what we call as peripheral vascular resistance. Why cars are not going more into road B? Because road B is smaller. Road B में तंगी ज़्यादा है. Road B is बहुत narrow है, तो घुसने में दिक्कत होती है. अब घुसने में दिक्कत का मतलब क्या हो कि रोड भी घुसने नहीं दे रहा. घुसने क्यों नहीं दे रहा? क्योंकि पतली गली है. पतली गली का मतलब क्या? स्पेस ज़्यादा नहीं है. स्पेस ज़्यादा नहीं है का मतलब क्या? कि मैं तेज चला नहीं सकता, तो मेरी स्पीड पे रेसिस्टेंस है. It is the resistance offered by the road B which is not allowing my car to go into road B. Hence, I'm going to road A. So road A is not the road of choice. It is by default I'm going to road A because road B is tangali. Okay? So you need to understand peripheral vascular resistance is the resistance offered by the blood vessels on non-vital organ so that more amount of blood can go into vital organs. In a simple concept, vital organs का blood vessel इतना मोटा होता है और non-vital का इतना छोटा होता है. तो obviously when you look at the lumen, इतना बड़ा आपका, you talk about this is the size of the vital organ or the blood vessel of the vital organ. This is the size of the blood vessel of a non-vital organ. So when the blood has to flow, obviously it will flow into a bigger hole. So because the vessels of vital organs are bigger in caliber, they will have low resistance. So more amount of blood is going to be flowing into the vital organs. Less amount of blood will go into non-vital organs. So again, यहाँ पे vital non-vital का जो खेल है, the peripheral vascular resistance, नाम ही है ना peripheral vascular resistance. It is the resistance offered by the blood vessels of the peripheral vessels or the peripheral organs, or I can say non-vital organs, where more amount of blood is going into vital organs. And this is what we call it as the PVR. From here, the blood is now going to come into the vascular pool. So we'll take this as the representation. We'll take this as a representation of the vascular pool. So imagine the entire pool of the blood is concentrated here. From here, it will go into right atria, and the circuit will continue to happen. Just for the sake of understanding, you will notice. Okay, we'll make it more interesting for us. So this is the amount of blood that is going to be present in the left ventricle. We have already said the amount of blood available left ventricle before the contraction is what we call it as the preload. From here, as the blood ejects out, it goes into the circulation, and this is your peripheral circulation. I can say the aorta is circulating. Now, as it comes to the junction, it has to divide into two components. One that is going into the vital organs. You will have more amount of blood going into the vital organs. Obviously, the requirement is more, but more importantly, the blood is not going because the requirement is more. The blood is going more into the vital organs because of bigger calibered blood vessels. Whereas the blood going into the non-vital organs are less because of lower calibered, or I can say there is more resistance offered. There is more resistance offered. There will be more resistance offered from the non-vital organs. Hence, there is less amount of blood going into the non-vital. More amount of blood is going into the vital organs, right? So from here, eventually what is going to happen? The blood is now going to be collected from both vitals and the non-vital organs, and they will now accumulate in the vascular pool. They will now get accumulated. So blood from the vitals as well as blood from the non-vital organs will now get accumulated into the vascular pool. From the vascular pool, it is now going to go into the right side of the heart. Now from the right side of the heart, it is now going to go into the right ventricle. It is now going to go into the right ventricle, and from the right ventricle, it will now go back into your left atria, and from left atria it will go into left ventricle, and from there it will go. So this is the entire circuit that is going to happen. I hope everybody is able to understand the circuit. There's nothing spectacular about it. You see the blood coming from the left ventricle goes into the aorta. From the aorta, it is circulating. You'll see more amount of blood going into vitals, less amount of blood going into the non-vital organs. Eventually, both of them are pouring the blood into your vascular pool. The blood from the vascular pool is now circulating back into the right atria. And from the right atria, it goes into right ventricle. From right ventricle to left atria. From left atria to left ventricle. And the circuit goes on and on and on. Okay? This is the basic circuit and the basic concept that you need to understand with respect to circulation. To make our life easy, I'm going to give them special names. Nothing so special, basic ones, right? So we'll call it as compartment A, we'll call heart as compartment B, and the peripheral vascular resistance is compartment C. I've named as three simple compartments. The vascular pool is called as compartment A, the heart is called as compartment B, and the peripheral vascular resistance is called as compartment C. Okay? Now, whenever there is a damage in your vascular pool, that is in compartment A, this is what we call as hypovolemic shock. Whenever there is restriction or damage in the heart and the blood is not able to pour in or circulate, we call it as cardiogenic shock. And whenever there's a problem with peripheral vascular resistance, that is damage in compartment C, will be called as your distributive or septic shock. Damage in compartment A will result in hypovolemic shock. Damage in compartment B will result in cardiogenic shock, and damage in compartment C will result in septic shock. As simple as that. Clear? Okay. Everybody sorted? Now, with this information in hand, we'll try to work up the entire picture of shock. कि ये हो क्या रहा है, ठीक है? तो ये shock में क्या shock लग गया, ठीक है? We'll try to understand the hypovolemic shock. Now, imagine in a hypovolemic shock, there is damage in the vascular pool. Now, when there is damage in the vascular pool, what is going to happen? The blood which is available in the vascular pool will now start to leak out. Now, as the blood in the vascular pool will result or leak out, what will happen? The blood volume in the vascular pool will reduce. If the blood volume in the vascular pool is going to reduce, that is the blood going into the right atria will also reduce. If the blood going into the right atria will reduce, what will happen to the right atrial pressure? See, the blood in the vascular pool is leaking out. The volume of blood in the vascular pool is going to come down. That means the blood going back into your right atria will reduce. Okay? In a simple concept, if you see all this, you will now see the blood is started to reduce. Right? So you'll now notice the blood will start to reduce here. So blood in the vascular pool is started to reduce. If the blood in the vascular pool will reduce, the blood in the right atria will reduce. That is what we're trying to tell you. So what is going to happen? The blood in the right atria will reduce. So the right atrial pressure will fall. I repeat again, the blood in the vascular pool is reduced. The blood going into the right atria is reduced. The right atrial pressure will drop. The right atrial pressure is measured by JVP, and the JVP is going to reduce in hypovolemic shock. The right atrial pressure is determined by the amount of blood coming into the right atria. The pressure in that chamber is determined by the blood volume that comes into right atria. Volume drops, pressure drops. If the blood in the right atria is less, the blood in the right ventricle will also be less. If the blood in the right ventricle is going to be less, that means the blood going into your left atria will also reduce. And if the blood volume in the left atria reduces, left atrial pressure will drop. The left atrial pressure is measured by pulmonary capillary wedge pressure. So in hypovolemic shock, you will see the pulmonary capillary wedge pressure will also reduce. If the pulmonary capillary wedge pressure reduces, the amount of blood going into the left ventricle will also reduce. If the amount of blood going into the left ventricle reduces, we all have already discussed, right? If you talk about this is the left ventricle, the amount of blood going into the left ventricle, if it reduces, left ventricular volume before the contraction is what we call it as preload. So I'm simply telling you the preload is going to reduce, and whenever the preload reduces, we have already seen, no, the preload, if we say cardiac output is measured as preload minus after load. So you now see the preload reduces, so obviously the cardiac output will also reduce. So in hypovolemic shock, you see there is decrease in cardiac output. We have already discussed, whenever there is decrease in cardiac output, the blood coming from the heart, the blood coming from the left ventricle into the aorta is going to reduce. So the volume of blood coming in the aorta reduces, so aortic pressure drops. The aortic pressure is measured by systolic blood pressure, so hence the systolic blood pressure will reduce. Hence the systolic blood pressure will reduce. If the systolic blood pressure reduces, the baroreceptors get activated. Activation of baroreceptors. Activation of baroreceptors. Activation of baroreceptors will cause activation of sympathetic pathway. One second, what happened to my document? So whenever the baroreceptors get activated, activation of baroreceptors will cause activation of sympathetic pathway. Activation of sympathetic pathway will cause excessive release of epinephrine and norepinephrine. The effect of epinephrine and norepinephrine on the heart, it increases the heart rate. So you now see there is increase in heart rate. You now see there is increase in heart rate. Okay? Now, until this point, we are fine. You see the systolic blood pressure is dropping, the heart rate is increasing, the body is trying to compensate every single thing that is there. What will happen to the peripheral vascular resistance? You now notice the amount of blood available for the circulation is reduced. So body wants whatever amount of blood is there, you want more amount of blood to go to vital organs. Okay? So how will you do that? I will make this vessel even more smaller. If I make the non-vital organ even more smaller, more amount of blood will now be forced to go into the vital organs. How can you achieve that? By increasing the peripheral vascular resistance. When I'm causing the vasoconstriction of non-vital organs, that means I'm increasing the resistance for the blood flowing into them. अगर मैं नॉन वाइटल ऑर्गन्स की ब्लड वेसल को और छोटा बना रहा हूँ तो नॉन वाइटल ऑर्गन्स में रेसिस्टेंस और बढ़ा रहा हूँ ब्लड फ्लो के लिए, क्योंकि ब्लड और इजीली नहीं जा पाएगा तो रेसिस्टेंस बढ़ जाएगा ना नॉन वाइटल में. तो क्या होगा? अल्टीमेटली मोर अमाउंट ऑफ ब्लड विल गो इनटू वाइटल ऑर्गन्स. स्किन इज एन एग्जांपल ऑफ नॉन वाइटल ऑर्गन्स एंड ब्लड इज रिस्पॉन्सिबल फॉर कैलोरी जेनेसिस. अगर ब्लड स्किन में जाएगा ही नहीं, कम जाएगा, तो कैलोरी जेनेसिस विल बिकम लेस. इफ द कैलोरी जेनेसिस इज गोइंग टू बिकम लेस, द स्किन टेम्परेचर इज गोइंग टू फॉल एंड हेंस रिजल्टिंग इन कोल्ड peripheries. Hence resulting in cold peripheries, right? So this is all in all that you should know in the context of hypovolemic shock. Is everybody clear with the parameters at how we worked up each individual component? Clear? Clear? Chalo. So we'll go with cardiogenic shock. That how do you work up the basic status of the cardiogenic shock? Now, in the cardiogenic shock, I am saying the heart is not able to contract effectively. So you need to understand in cardiogenic shock, the problem is the blood in each individual component remains. So in a cardiogenic shock, the heart is not able to pump effectively. Now, because the heart is not able to pump effectively, all four chambers of the heart will now be filled up with the blood. Okay? So you say in a cardiogenic shock, the heart is not able to pump effectively. Now, because the heart is not able to pump effectively, you will see there is some amount of blood that will be present in the right atrium. There will be some amount of blood that will be present in right ventricle. It is not able to pump effectively. So all four chambers will be now filled up with some amount of blood. In a cardiogenic shock, the problem is that the heart is not able to eject out the entire volume of blood. So some amount of blood will still be left behind in the heart, and this is what we call it as cardiogenic shock. So in the cardiogenic shock, the heart is not able to evacuate the blood that is available. It is not able to evacuate the blood. So say in a cardiogenic shock, all four chambers of the heart are filled up with the blood. Okay? So चारों के चारों chambers blood से भरे हुए हैं. They are filled up with the blood. So this you say is the right atria. This is the right ventricle. This is the left atria, and this is the left ventricle. All four chambers are filled up with the blood. Now, because all four chambers are filled up with the blood, they are not able to eject enough amount of volume. Their heart is not able to contract effectively. So blood going from the heart into the aorta reduces. And that is what we call it as the cardiac output. So you will now notice the cardiac output in the cardiogenic shock reduces. Right? Now, as the amount of blood going from the heart to the aorta drops, the aortic pressure drops. The aortic pressure is a systolic blood pressure, so it drops. As the amount of blood going into the aorta decreases, so volume decreases, so hence pressure decreases. So systolic blood pressure drops, baroreceptors get activated, sympathetic system, catecholamine, epinephrine, norepinephrine, the heart rate is going to increase. So in cardiogenic shock, in terms of compensation, you will see there is increase in heart rate. Now, amount of blood that is going into the circulation is less because the blood coming out of the heart is less. So blood reaching to both vitals and non-vitals are less. Now, body says, I want to send more amount of blood to vital organs. How do I achieve it? I again make my peripheral blood vessels smaller. I cause vasoconstriction in the non-vital organs. So hence more amount of blood can go into vital. How do you achieve that? By increasing the peripheral vascular resistance so that more amount of blood goes to vital, less amount of blood goes into non-vital organs. One of the examples is skin temperature. I can say skin is a non-vital organ. So blood going into the skin is less. Calorigenesis in skin reduces. So hence skin temperature falls. Hence you will notice the skin temperature reduces. Again in your cardiogenic shock, you will see cold peripheries which are present. Now, the amount of blood going into this peripheral circulation is less. Blood going into vital, non-vital organ is less. Blood coming to the vascular pool is also less. Blood going back to the right atria is also less. So what should happen to right atrial pressure? If you think by that logic, right atrial pressure should drop. But it will not drop. Why? Because some amount of blood which is going from here into right atria, already right atria some amount of blood already no. So already right atria भरा हुआ है, उसमें और थोड़ा drop off डाल रहे हो, और थोड़ा blood डालोगे तो obviously right atrial pressure will further shoot. Remember in cardiogenic shock, all four chambers are filled up with the blood. They are not able to eject the blood out. Hence all four chambers are pressurized. When all four chambers are pressurized, I can say pulmonary capillary wedge pressure as well as your JVP will increase in cardiogenic shock. It will increase in cardiogenic shock. Is the concept clear? Okay. So this is how you will work up your cardiogenic shock. Anybody and everybody who's listening to this video, please do not think कि मैं याद रख लूँगा कि ऊपर नीचे होता है arrow और मुझे exam में याद आ जाएगा. ना. If you do not understand this circuit, if you do not understand the basic concept behind every single point that we are trying to emphasize, there is no use me trying to put so much amount of effort. Okay. So I hope everybody understood the cardiogenic shock. Now we'll talk about the BAP of all shock. That is going to be a septic shock. Because septic shock, no, to be very honest, it is not difficult. Septic shock में थोड़ा सा concept लगता है. ठीक है? Septic shock is basically, we say there is loss of peripheral vascular resistance and there is universal vasodilation. Two things that you have to remember in septic shock. There is loss of peripheral vascular resistance and there is presence of universal vasodilation. So when I say universal vasodilation, in universal vasodilation, I'm talking about the aorta is getting dilated. Every single blood vessel from capillary to aorta gets super dilated, and that is the problem in septic shock. Okay? So to understand septic shock, we'll reconstruct every single component that we have here. So we'll see what is going to happen to the septic shock blood volume. So the same representation, nothing changes, just for the sake of understanding. So we have, this is the right atria, this is the right ventricle, the left atria and the left ventricle. Okay? Now we try to understand that in septic shock there is loss of peripheral vascular resistance. If there is loss of peripheral vascular resistance and universal vasodilation, what is going to happen? The aorta is going to become super dilated. So this is how the aorta is now going to look like. Problem is not the aorta looking like this. You will now see that even your non-vital organs are going to get super dilated, right? So if you look at the caliber of your vital organs and the caliber of the non-vital organs, they almost become same. The vital organ and non-vital organ जो caliber है, they become bigger, and the aorta is also distended. Okay? So in a septic shock, you will now notice the aorta, which was initially like this, is now become like this. Now because of this, what is going to happen? Let it be vital or non-vital organ, it doesn't matter. Let it be a vital or a non-vital organ. So this is the aorta which is getting super dilated. So in the septic shock, you see the entire component of the vitals and the non-vital organs is going to get distended. So you now see the caliber of the vital vessel and the caliber of the non-vital organ is almost same. So the blood that is going to flow, is now going to go into the aorta. From there it will enter into vital, and same amount of volume will enter into non-vital organs also. That is the whole objective here. So in a septic shock, there is loss of peripheral vascular resistance, universal vasodilation, hence causing the problem. Now, if you want to understand the basic concept behind it, just for the sake of understanding, I'll give you an example, right? Initially, what used to happen, there used to be 100 ml of blood. Imagine there's 100 ml of blood that is pumped into the aorta. We'd say the 80 ml of blood will go to vitals and 20 ml of blood will go into non-vital organs. This is normal because the requirement for the non-vital is only 20, but the requirement for vital is 80 ml. That is the basic concept. Okay? When a patient is having a septic shock, what is going to happen, or a distributed shock? There's a vasodilation of all the vessels, including the vital and non-vital. Peripheral vascular resistance is lost. Now, because of this, 50 ml of blood is now going into vital, 50 ml of blood is now going into non-vital organ. Normally, 80 ml would have gone into vitals, 20 ml would have gone into non-vital organs. The requirement of non-vital is 20, the requirement of vital is 80, right? But now because of septic or distributed shock, you now see 50 ml going into vital, 50 ml going into non-vital organs. So what is happening? The requirement for the vital is 80, you're giving 50. So where it is required, you're giving less. And the requirement of non-vital is 20, but you're giving 50. Where it is not required, you're giving more. So all your vital organs are under-perfused, they're hypoperfused, hence the status of shock. Your survival depends upon your vital organs, not on your non-vital organs. No matter how much amount of blood you give to non-vital organs, you will not be able to sustain if the perfusion to the vital organs is being pulled out. It is the same funda in life. Where you have to put effort, you should give maximum amount of time, and where you should not put effort, you should give minimum amount of time. लेकिन life में उल्टा होता है, right? जहाँ पे लगाना चाहिए दम, वहाँ पे आप नहीं लगाते हो, जहाँ नहीं लगाना वहाँ पे फालतू में झोंकते रहते हो, ठीक है? So this is your body is trying to teach you. Where you require it, give it more. Where it is not required, you don't need to. If you do that, it will result in shock. और वही life में भी लगता है, झटका ही लगता है ना. That is what I'll talk about. So remember, efforts should be very judicially involved, and you should be very judicially be spending on those efforts. So यहाँ पे भी body क्योंकि you're not doing a good spend, it is now going into a state of shock. ठीक है? Now what is going to happen is going to be our game to understand. So septic shock में there is loss of peripheral vascular resistance. That is what we understood. Now, because there's loss of peripheral vascular resistance, what is going to happen? The blood going into non-vital organs increases. Skin is an example of non-vital organ. So what will happen to the blood flow in the skin? Increases. Blood is responsible for calorigenesis. What will happen to skin temperature? It will increase. यहाँ तक सबको clear है, किसी को कोई doubt हो ही नहीं सकता. Now what is going to happen is, I am saying 100 ml of blood used to go 80 to vital, 20 to non-vital. When it comes back to vascular pool, how much amount of blood was initially coming back? 100 ml. क्योंकि 80 vital से 20 non-vital से आना वापस 100 ही है. अब क्या हो गया? 100 में 50 vital, 50 non-vital, but coming back to vascular pool is how much? Same 100 ml. So blood coming back to the vascular pool will not change. So this volume that is going to come back to the vascular pool remains same. That means the amount of blood going into the right atria will also remain same. That means the right atrial pressure will also remain same. And right atrial pressure is measured by your jugular venous pressure. So JVP remains normal. If the blood going into the right atria is normal, the blood coming back to the right ventricle is also normal, coming back to the left atria is also normal. So left atrial pressure will also remain normal. And that is your pulmonary capillary wedge pressure. Okay. Now, if the blood coming into the left atria is normal, the blood coming into the left ventricle will also remain same. That means preload is same. If preload is same, the amount of blood going into the aorta will also remain same. That is stroke volume per contraction. No. So amount of blood ejecting out of the left ventricle into the aorta will remain same. That means the stroke volume will also remain same. If the stroke volume remains same, what will happen to your cardiac output? We'll come back to that later. But now imagine if the amount of blood coming from the left ventricle into the aorta is same, I will expect the aortic pressure to be same. लेकिन problem क्या? Aorta तो dilate हो गया. Amount of blood coming into the aorta remains same, but the size of the vessel becomes super dilated. What will happen to net pressure in the aorta? Aorta का lumen बड़ा हो गया. Volume of blood coming is same. Lumen is bigger. So what will happen to net pressure? पहले क्या था? Volume जितना था, उसका जो capacity था ना, वो भी उतना ही था. ठीक है? So lumen was same. And the volume coming was also same, so pressure was normal. That was same. अब यहाँ पे क्या हो रहा है? The amount of blood coming into the aorta remains same, but the size of the aorta gets super dilated. So hence the net pressure in the aorta drops. So aortic pressure क्या है? Systolic blood pressure. So I can say systolic blood pressure reduces. अगर systolic blood pressure reduce हो जाएगा, baroreceptors, epinephrine, norepinephrine, what will happen to heart rate? It is now going to increase. The heart rate will increase. अब cardiac output क्या होता है? Cardiac output can be measured. I can say the cardiac output, just for sake of understanding, cardiac output can be measured into stroke volume into heart rate. अभी हमने इतना सीखा है कि स्ट्रोक वॉल्यूम क्या होता है पर कॉन्ट्रैक्शन. तो पर कॉन्ट्रैक्शन में क्या हो रहा है जी? पर कॉन्ट्रैक्शन में हमारा स्ट्रोक वॉल्यूम है दैट रिमेन सेम, सो इट इज नॉर्मल. ठीक है. व्हाट इज गोइंग टू हैपन टू द हार्ट रेट? अभी आप देख रहे हो हार्ट रेट यहाँ पे इंक्रीज हो रहा है, तो इस इक्वेशन से नेट कार्डियक आउटपुट क्या हो जाएगा? इंक्रीज हो जाएगा. ठीक है. सो स्ट्रोक वॉल्यूम रिमेन सेम बट द हार्ट रेट इंक्रीजेस, सो नेट कार्डियक आउटपुट इंक्रीजेस. सो इन सेप्टिक शॉक cardiac output initially increases as a state of compensation. Is that clear? देखो, शॉक को समझने के लिए आपको तीनों varieties of shock in a very conceptual manner and a very comparative manner you should be able to know it. ठीक है. इसको बैठ के मगअप कर लोगे, इसको बैठ के ऐसी चाट लोगे तो नहीं होगा. Shock is something that you need to understand. It's a very basis when you're managing trauma, when you're managing wards, when you're managing your basic postings. कहीं पे भी अगर कोई भी पेशेंट शॉक का मैनेज कर रहे हो, देखो कोई भी पेशेंट डायरिया के साथ आता है, ठीक है, एक्सेसिव वॉल्यूम लॉस, हाइपोवोलेमिक शॉक, एक्सेसिव वॉमिटिंग, हाइपोवोलेमिक शॉक, पोस्ट ट्रॉमा, व्हाट इज गोइंग टू हैपन? हाइपोवोलेमिक शॉक, ब्लड लॉस हो गया. कोई भी पेशेंट है जिसको कार्डियक इशू है, कार्डियोजेनिक शॉक के साथ है, किसी के साथ इन्फेक्शन है, डायबिटिक फुट के साथ है, उसको सेप्टिक शॉक है. सो इन ऑर्डर टू आइडेंटिफाई दिस इज बेसिस ऑफ योर प्रैक्टिस ऑन अ डेली बेसिस. अगर आपको शॉक नहीं समझ में आता है, आप अपने डेली इमरजेंसीज नहीं मैनेज कर पाओगे. ठीक है. So this is the basis of understanding the various components of shock, right? Kulvinder, we will continue this series, beta. We will continue until we finish the entire portion of general surgery, which is written to the T on Bailey and Love. So that's our promise, and we will achieve it no matter what. Okay? See, I'll make BLS the best open free series to learn general surgery, no matter which part of the world you are. Right? I will put equal amount of efforts to bring every single topic, break it down to a small understandable portion, and so that you understand to best of your knowledge. Okay? Chalo. Alright guys. So this is it for today. आज सिर्फ शॉक का बेसिक हमने किया है. कल हम वैस्कुलर इंजरीज और उनके ईच इंडिविजुअल मैनेजमेंट के बारे में बात करेंगे. विल टॉक अबाउट हाउ टू मॉनिटर शॉक, हाउ टू मैनेज शॉक. All that will be taken into consideration tomorrow. ठीक है. कल हम मैनेजमेंट ऑफ शॉक एंड वैस्कुलर इंजरीज का टॉपिक कंप्लीट करेंगे. ठीक है. With that, thank you so much for joining. Right, loads of love and loads of appreciation for every single student who comes on live, attends the lecture. See, we started the series. I know it's not a great live watching audience, but I'm super happy with whatever I am having. We are having a gradual growth. We started with an average number of 10 to 15 students. Now we have gone to 25 to 30 students. As we continue to do so, there will be a day where I will take live lecture with more than 10,000 people attending live. And that's what we'll be achieving with BLS, right? So thank you so much for joining in and signing off for today. We'll see you tomorrow, same time at 9 p.m. If you have any questions, any queries, where to reach out. For the Instagram and Telegram, you can reach out on the context, that is the surgery guy. So both Telegram and Instagram, this is what you have to follow. It is by my name, that is Dr. Sandeep Seeram Reddy. With that, thank you so much. See you guys tomorrow, same time at 9 p.m. to 10 p.m. Thank you so much. Bye-bye. And all the FMG bachas who are writing their exam, all the very best. Continue working hard. Do not give away in this last minute. Aakhri 1 week hai. Just give every single ounce of blood that you have. All right. Thank you so much. For all the final year bachas who are going to attend, we are also starting a series called as Farre, which is going to be your exam questions. All the important university exam topics will be covered in the series of lectures. We have designed 8 lectures for surgery to complete your entire general surgeries topics for your university exam. So yes, Farre is coming for final year also. We'll be doing surgery there for university exams as well. Thank you so much. बेटा बेली चाहे इधर से उधर हो जाए, ठीक है, चाहे कुछ भी हो जाए, नो मैटर व्हाट वी विल फिनिश बेली. ठीक है, एवरी सिंगल चैप्टर इन बेली हम टी टू टी करेंगे. दैट्स अ प्रॉमिस. ठीक है, BLS सीरीज विल कंटिन्यू टू रन नो मैटर व्हाट एंड हाउ एवर इट टेक्स. ठीक है, चलो, थैंक यू सो मच. बाय बाय, गुड नाइट, टेक केयर.